Thank you very much. I thank the organizers for giving this opportunity yet again. This is my fourth Trendo straight, and thanks for giving this opportunity. And I thank them that it's at least, initially I was a little afraid it's a post-lunch session, not many people will come, and it's a post-prandial sleepiness, but luckily it is before 3 p.m. After 3 p.m. the crowd may become even lesser to watch the match. Anyway, so quickly going on to this topic, precision medicine and diabetes. Now, the word precision is important to understand. There are the two terms called precision and accuracy. On the left side of the screen that you see, the dart arrows are hitting right in the inner circle. That is what is called accuracy, how close you are to the target. Whereas precision actually means the second picture on your right. Precision exactly means how close you are every time you attempt the target. So, in other words, although we don't develop treatments for one particular individual, if you can cluster your patients into patients with unique features, which may be genetic, which may be clinical, which may be biochemical, and if you can define them clearly and treat them in more efficient ways, that will be called precision medicine. Other words, stratification of patients into groups on basis of molecular and genetic biomarkers and clinical characteristics to optimize therapeutic outcomes. This is what precision medicine. This has taken up a huge effect on cancer treatments. Nowadays, I'm sure you all know, breast cancer treatments, the oncologist can decide if the mutation is positive, whether it is estrogen receptor positive or is negative, and they decide whether they have to give the HER2 new antibodies or not. So they are so well designed in terms of therapeutics. Similarly, for lung cancer, they have similar molecular markers and then decide. Unfortunately, we don't have such level of precision as far as diabetes is concerned. The biggest problem that we have with diabetes is its heterogeneity. I mean, we know the broad classifications of type 2 and type 1, but then there are a lot of these smaller fragments. There is the maturity onset diabetes, there is the monogenic diabetes, then you have the latent autoimmune diabetes of the adult, ketosis prone diabetes. So we starting to subdivide the other bigger into smaller fragments, and it starts to become very heterogeneous. So it's difficult for us to judge. One of the reasons why we are not able to apply precision medicine so effectively in diabetes care. I'm sure these are some of the bigger challenges we have in applying precision medicine in diabetes. We've all seen patients who have been lean, antibody negative, but they've not developed ketosis. They're doing pretty fine. You put them on tablets and they do well. You also have the childhood onset antibody positive diabetes, but they are quite insulin resistant. They require high dose of insulin. They may need other tablets to also overcome some of the insulin resistance. We also know people who progress very rapidly with microvascular or macrovascular complications. On the contrary, we also see patients who have been doing well on a small dose of sulfonylurea for many years without any complications. We also really cannot predict the rate of beta cell failure, although there are various studies from the West which we sort of extrapolate the information. We really cannot predict for a given patient who coming and sitting in front of us in the clinic what is going to be the rate of beta cell failure. We also would be difficult to judge how much of weight loss is required to reverse or normalize glycemia. I think Dr. Arun Menon gave a little hint on to how to reverse diabetes with weight loss, but again, degree of weight loss required to reverse, very difficult to judge for a given patient. Type of medication best suited for a given patient. Again, these are all the challenges that we have when we are trying to apply this precision concept in the field of diabetic therapeutics. Now, the one area where precision medicine has taken a huge advancement is in monogenic diabetes, particularly when you have examples of monogenic diabetes where you have the G6K deficiency, glucokinase deficiency, where it's a purely sensing disorder you don't treat, where you have a HNF4 alpha, that's a very common disorder where you could treat them with sulfonylureas, where you have a KCNJ or a HNF1 alpha, then you put them on sulfonylureas, and then if you have the other PPR gamma effect, then ectopic fat may be responding to metformin. So we have some very specific monogenic diabetes where precision medicine will work very nicely. But unfortunately, things are very heterogeneous. As you can see on the figure on the right, it's a complex trait. So you really don't know whether you are using a sensitizer or a secretagogue or an incretin-based therapy. Now with the SGLT2 in the picture, it has made it even more complex which treatment is the right option for a particular given patient. But let's not forget, we all practice medicine, we all do conduct some amount of research, whether it is a small clinical research or a bench research or a trial based with a pharmaceutical company. We get a whirlwind of data. I'm sure some of the people sitting in this audience must have be seeing diabetes patients for quite a long time, and if you were to rigorously or religiously collect the information of your own patients, I think we would generally be having huge amounts of data that we can actually mine back into. You have data based on the phenotypes, which may include the age, gender, BMI, comorbidities, biological markers like C-peptide, HbA1c, markers of insulin resistance. Then you also have some genotypic data which may be available from certain genetic testing available, which is possible to be done, and those also sometimes dictate the precision medicine. So you have genotypic data as well as phenotypic data. So when we try to mix both of it, that's when we're able to get into big data meets biology. Diagnostic tests and therapies are selected on the basis of not only all these very complicated genetic testing, but also on very specific risk factor profile and health history obtained from health record. I will show you a few examples on why this family history becomes very important. Sometimes when we see a lot of number of patients with diabetes, we sometimes ignore the family history. Family history may be something very, very critical, and the person will very clearly tell you, sir, my brother also has diabetes, this drug has been given, he is doing very well for the last 5 years. Take that history, that's very important. That may be a clue that your patient also may be responding to that particular drug which he says. Another very common scenario, patient has been on well controlled on two drugs, the sulfonylurea and metformin. They have underwent some kind of a surgery. After the surgery, very religiously the doctor in the hospital would have put them on insulin. Post insulin, sugars are not very well controlled, hiking up the insulin, nothing is working. The patient will silently tell you before going, sir, before the surgery I was on that tablet, it was working very well, sir. Why don't we just try the tablet again? And then you try the tablet, you see it works very well. These are all very important clues. These may not be your magic genetic marker that you're doing, but these are very important clues in history that you pay attention to, and this may be very valuable in your outcome of patients. So to sort of give you the idea or the logic of what this talk is trying to take you to is to look at clinical based categories, look at then the biochemical and the clinical and the genetic markers that we possibly have. Some of them we may not have all the markers at our hand, at our disposal every day at the clinical practice, but then the idea is to combine these two so that you can develop clusters of patients. So if I see a particular pattern of patient, and I will give you some examples at the end, if I see a particular pattern of patient, then my approach is going to be this way. And if I see this pattern of patient, my approach will be this way, guaranteeing that approach will work very well. And that comes with experience, because this is an evolving field. We really don't have a magic bullet that will tell us, okay, you do me this test will tell you whether you will respond to DPP4 or GLP1 or SGLT2 or sulfonylurea. There is no test like that for us right now. So what we best have is to cluster your patients into categories that may actually tell you which one they will work. And I'm going to show you a Scandinavian paper where they are able to show that the clustering can also help you predict what complication they will get into. So this becomes very critical when you're managing patients with diabetes. Now, my talk was on precision diabetes, and I'm stuck to management. I'll just put 2 slides because there are certain amount of precision that is also involved in the diagnostics and in the food related issues. So I will just put 2 slides and then we'll go on to therapeutics. So there is obviously some of the older sulfonylureas, particularly glibenclamide use, can be contraindicated in patients who have G6PD deficiency. So it is important that you check G6PD in patients sometimes. And luckily, in this part of the world where we live, the G6PD deficiency is rather rare. So we don't encounter this. But in Africa, the patient has the right to tell the doctor to get a G6PD deficiency before initiating older sulfonylureas. The Greenland population also identified a mutation in the TBC1D4 gene, which again substantially increased the risk of type 2 diabetes. So there are markers that can tell you, okay, what is your risk of diabetes? Sir, I am we have the Indian diabetes risk calculator. We also have now genetic markers that can tell you are you at a risk, are you at a higher risk of developing diabetes or not? So these are all from the diagnostics point of view. These are more in terms of population based and government policy based. So I'm not going to get into this part of it. One more important thing that I will just touch upon is macronutrient intake associated FGF21. FGF21, remember, is kind of like the energy, molecule that controls the weight loss as well as the energy expenditure. So it depends on how your FGF21 genotype. This is not FGF23. We are all familiar with FGF23 related with calcium and phosphorus metabolism. Here FGF21 is more related to the weight loss and body composition. And in fact, the study from this group were able to tell that it depends on how your FGF21 is that influences your weight loss pattern. So suppose somebody's got a particular genotype of FGF21, they will lose weight only with a low fat diet. They may not benefit with a low carbohydrate diet. So you can actually tailor your weight loss management based on some of the genetic testing available. So again, precision testing for what kind of therapy you're going to offer. Now the Israelis have developed this kind of an artificial intelligence software which takes into account the food intake, the anthropometrics, questionnaires about their activity, blood test, and most importantly on the top here you see microbiome. Microbiome also decides your glycemic response. People would have told you many times in the history, sir, adhe rendu idli da sir, ana inniki 140, adhe rendu idli 3 நாளைக்கு அப்புறம் 240. Why the same food, same carbohydrates, same amount of meal, same surrounding sambar and chutney, one day is particular number, one day is a higher number. What influences the change suddenly that day? So that there is an inborn, there is also the microbiome that decides your glycemic response. So the Israelis have shown it in a small number of patients. I think we're awaiting more bigger data, more wider population. So you can design personalized diet to lower glycemic response. Sir, I ate rice, my sugars are less. When I eat my chapati, the sugars are higher. So again, personalized diet plan is very important. Not a one thing fits all will ever suit. That's why when we tell patients to monitor their sugars, we also take a feedback for yourself. Eat your food, see where your sugars are. If a particular food is suiting you and you're well controlled on that, stick to that plan. Don't go by what is suited other person. In coming to therapeutics, now metformin has been one of the longest staying drugs, and in fact it has been one of the very closely studied drug in terms of pharmacogenomics. There has been study of the OCT1 or the SLC22A1 gene, and if you have an abnormal variant of this OCT1, you are likely to have more of metformin intolerance. There are also genes that regulate metformin release into the bloodstream. There is also genes that regulate metformin excretion in the kidney into the urine. So genetically, you can actually be designed to tell if you are going to be a metformin responder or a metformin non-responder. Genetically, you can also be programmed to tell if you are going to have side effects to metformin or no side effects to metformin. Again, these have not been able to replicate in large number of patients. So there is also another molecule called SERT uptake reuptake transporter, again involved in metformin intestinal absorption. So if you have a low expression of SERT alleles, you are having a higher odds of developing metformin intolerance. But unfortunately, this has not really transformed into we cannot be testing OCT gene variation in people. Metformin is a cheap drug. That is the number one drug we start for most patients with diabetes. And I think that's a very logical thing to put them on metformin. If they have side effects, reduce the dose. Still have side effects, you withdraw the drug. That's as simple as it is. Two important personal observation, not backed by hardcore scientific data, that BMI intolerance is linked to BMI gender. The lower your BMI, the lesser you will be able to tolerate the metformin dose. So if you have somebody who's got a BMI of 20, 21, if you put them on a 2 gram, 1 gram BD dose, likely to have more side effects than compared to somebody who's got a BMI of 20, 28, 30. Females generally have a higher tendency to develop metformin intolerance compared to males. Similarly, metformin's chance of failure as a single monotherapy is inversely related to the dose used. You use a smaller dose to treat diabetes in the beginning, you are likely to fail monotherapy if you use a smaller dose. You are likely to have a more persistent durable effect if you are going to use a higher dose. So broad implementation of pharmacogenomic analysis for clinical prediction of metformin efficacy and tolerability is not practical, not cost effective. Coming to sulfonylureas, the next most important drug that we use in diabetic practice. As you all know, the sulfonylureas act at the SUR, the sulfonylurea receptor gene, which is closely linked with the KIR 6.2 KCNJ1 channels, thereby causing a potassium ATP channel to close. This causes depolarization, resulting in calcium influx. Calcium influx results in insulin release, further action of insulin. And so there are genetic markers to suggest will you be responsive to sulfonylureas or not. And again, the best studied group of patients in whom pharmacogenomics has really helped or precision medicine has helped is single gene disorders. I showed you this image before, is the monogenic diabetes, particularly the HNF4 alpha, which is the commonest form of in the West. HNF4 alpha responds beautifully to sulfonylureas. HNF1 alpha responds to sulfonylureas, but you may need a higher dose. I mean, you may need insulin later on as the medicine starts to fail out. The third drug that has been studied from a genetic point of view or a pharmacogenomics point of view is thiazolidinediones, particularly rosiglitazone, not much on pioglitazone. Again, the OATP transporter in the liver, the PPR gamma in the skeletal muscle and the adipose tissue decide the action of TZD, and people with genetic variation in the PPR gamma may have decreased responsiveness to TZD in some small Asian cohorts. There are particular CYP enzymes in the liver that are associated with reduced glycemic response to rosiglitazone and less weight gain, whereas there are some other genetic variants like SCLCO1B1 where they are associated with enhanced glycemic response, but also they have enhanced weight gain with rosiglitazone. Unfortunately, these variants have not been replicated with pioglitazone. One very practical, and I'm sure a lot of older people in this audience will appreciate this, that if you have somebody who's been difficult to control and is on a thiazolidinedione, things are working on well, please don't rock the boat. If you remove the drug, you're probably not going to be getting an equal drug to get the patient under good control. So the general rule of thumb, if you have TZD, unless there is absolute contraindication, heart failure, renal failure, edema, or if they have osteoporosis, fracture, generally don't remove the drug just because there are so many information right now about the side effects. But if it's working well for a patient, it's very hard to replace the drug with another equivalent molecule because they probably are genetically susceptible to work very well in that particular cohort. Let's go more into precision medicine and diagnostics. This is a young, a middle-aged man, but he had a young onset diabetes. His diabetes was diagnosed at the age of 25. His fasting was around 240. His hemoglobin A1C was 11%. Triglycerides 480, HDL 21, and ALT was 145. Anybody in the audience can shout out? What do you think the diagnosis is? Lipodystrophy, excellent. So look at the lack of facial fat. So there's a complete hollowness in the cheek. There's a lack of buccal pad of fat. Look at his biceps and his brachioradialis. You can see the sort of bulging musculature. So when there is a redistribution of fat, I have not shown you the sideward picture and the calf picture, the redistribution of fat, and there is an increased muscle tone. These are patients who have what is called lipodystrophy. A few points on lipodystrophy, because this will influence your therapeutic management, because you will have to use a sensitizer based regimen. Both metformin and pioglitazone work very well in this scenario. What is lipodystrophy? They are heterogeneous disorders characterized by varying degrees of body fat loss and redistribution, predisposition to insulin resistance. The two main components are genetic and acquired. The genetic is what I showed you. The acquired is very commonly seen with antiretroviral therapy for HIV. The common metabolic problems will be diabetes, insulin resistance, hypertriglyceridemia, and hepatic steatosis and steatohepatitis. So you will see a lot of metabolic syndrome, but when you see redistribution of fat, prominent musculature, then your thoughts should now focus on whether you're dealing with lipodystrophy. Management will include sensitizer-based regimens where you will need both metformin and pioglitazone. Metroliptin therapy, unfortunately not available in India, is probably one drug very specifically approved for treatment of generalized lipodystrophy. Case number 2, 36-year-old male underwent CABG, very young, underwent CABG at a very young age. He's also had diabetes for 10 years, so age of diagnosis was about in the 20s. Was treated with premixed insulin for about 4 years. Sugars were poorly controlled, A1C 8.8. Strong family history of diabetes in father's brother, and paternal cousins. And his father also had a CABG at age 43. So you suspect monogenic diabetes if you have any of these 3 important conditions. If the diabetes is diagnosed less than 30 years, or in less than 45 if you don't have any evidence of obesity or insulin resistance or metabolic syndrome phenotype, or in less than 45 if there are more than 2 generations in an autosomal dominant fashion. And technically they should not be having DKA, and they should be able to have a detectable C-peptide and an absent pancreatic antibodies. There are very specific features they might have. If you have glycosuria at a blood glucose level less than 180, that may trigger your suspicion for MODY. Marked sensitivity to sulfonylureas. I put them on sulfonylurea, they work very well. I stop it, things go out of control. That's a usual clue to MODY. And diabetic with extra pancreatic features, renal stones, renal cysts, renal normal abnormalities, abnormal liver function test can be seen with some of the classes of MODY. So again, that's very important. And let's skip that. There is a very nice MODY probability calculator where this is developed by the Hattersley group online. You can actually put in your patient's details, and it will actually tell you in the end what your risk of developing or having a positive testing for MODY is. And this patient's predictive value was around 15, 1 in 15. So it was quite high. So we ended up doing a genetic testing, and it did come back positive for HNF4 alpha. And currently is on glibenclamide, metformin, and empagliflozin. You would not even think of adding glibenclamide in somebody who's at CABG. Sulfonylurea is bad for the heart. For this chap, the drug works very well. His A1C is 6.6. He's doing well. We keep him on a close monitor. We make sure that he has no cardiac problems. But you remember that this is what is precision medicine. You want to take a detailed history. You want to make sure that what medicine works with a particular patient. And because of that history, we went back and got the genetic testing done, and it was very rewarding in this patient. So I think I end with, I quote this important line: maturity onset diabetes of young, seek and you will find. Take a detailed family history. I think I can't emphasize this more. If there is one take-home point of this talk, take a very, very detailed family history. They often offer you clue on what kind of therapeutics you have to do. Another very rare but interesting case, I just put it up here. 11-month-old infant born of second-degree consanguineous parentage, sensorineural deafness and cardiac congenital heart disease, diagnosed with very high sugars during one of the cardiac admissions, incidentally noted to have macrocytic anemia, MCV of 110, treated with insulin for 6 months. Sugar is not so optimally controlled. No ketoacidosis, GAD negative, C-peptide is detectable. What is the diagnosis? Macrocytic anemia, diabetes in a neonate, in an infant, deafness. You wouldn't believe this patient's sugars are now well controlled without insulin. This patient has a very rare condition called thiamine responsive diabetes. So this patient had a defect in the SLC19A2. This is very sensitive for thiamine responsiveness, thiamine responsive diabetes, and this patient has been on thiamine supplements, has been weaned off insulin, currently at 18 months of follow-up, HbA1c 6% without any anti-diabetic therapy. So this is again precision medicine. So when you put things together, find out what is best going to help the patient, this is important. I'm going to sort of come to the last part of my talk where I alluded to in the beginning. You want to create clusters of your patients to see which therapy will work well for them. I think the Scandinavians have shown us the right way. I think they have created 5 interesting subgroups. I won't go into the methodology of how this was done, but it's very interesting to look at the clusters. Cluster 1 is your clear-cut autoimmune diabetes, severe autoimmune diabetes. This is type 1 diabetes. These patients need insulin. There's no question. Cluster 2 are the tricky ones. They are thin, they look like type 1, but antibody is negative, their C-peptide is very low, and you are likely to mistreat them with drugs because they may have a partial response to sulfonylureas very early in the disease. This is what we technically are used to call LADA. Because of mistreatment for a longer period of time in the initial phase of the diagnosis, they are likely to develop retinopathy. So this is a cluster 2. Again, better to treat them with insulin as you would do cluster 1. Cluster 3 is a dangerous cluster. They have features of both severe insulin resistance, and they also don't have much insulin production as well. So there's a combination of both, and these are the patients who are at a high risk of developing nephropathy. There's a family history of nephropathy as well. Cluster 4 is your mild obesity-related diabetes, where patients are generally younger, much more obese, and they tend to have very mild diabetes. They usually respond very well to weight loss related measures, including dietary and other bariatric methods. The cluster 5 is your mild age-related diabetes. As you get older, over a period of time, your sugars will go up a little bit, drift up a little high. That's a mild age-related diabetes. Again, nothing causing alarming complications. So again, you want to be gentle with this group. So cluster 1 is your antibody positive type 1 diabetes. Cluster 2 is your antibody negative, so-called LADA. Cluster 3 is your SIRD, severe insulin resistant diabetes. Cluster 4, your obesity related diabetes, and cluster 5 is age related diabetes. So I just put up a summary of some of these scenarios into clinical picture. Quickly summarizing, you have a new onset diabetes, sugars are very high, you put them on insulin and then metformin. After about 3 months, the sugars are still high, fasting of 160 and PPBS of 240. Let's go from the start on the top here. Young age, early onset diabetes in multiple members of the family, exquisite response to sulfonylureas, and most of them surprisingly are from the Kerala state. And you will see they respond very well to metformin and sulfonylureas. Second scenario, young age, no family history of diabetes, lean phenotype, steatoria, very important. This may be pancreatic diabetes. You may need to continue insulin. Young age, no family history of diabetes, lean phenotype, early microangiopathy. If you have somebody who's developed microangiopathy very early in their disease, that means the diabetes is severe. These are the patients who are likely to have latent autoimmune diabetes of adult. So be very careful. You may have to continue them with insulin. Then you have your young age, strong family history of diabetes, but normal weight. You could use metformin, thiazolidinediones, and sulfonylureas. Thank you. And then your typical obesity patients, you can use metformin plus DPP-4 as SGLT2 or GLP-1. Elderly patients, sarcopenic, you could use metformin plus a drug which will not cause hypoglycemia. The last cohort is a very tough cohort where they have tried everything, they not work. You really have to do what you can for that patient, and you may not get a perfect answer, but you have to try all the methods that you have. I'll stop here. Thank you for your attention, and just a quick announcement that Karnataka Endocrine Society is doing a conference on the ISBMR for the this year 15th annual conference in Bangalore. So kindly register 19th and 20th of October. Thank you very much.
Any questions to the speaker we can take up? The case who underwent CABG, you identified MODY. So why you would still continue the metformin and SGLT inhibitor, or because you told you are trying to be precise? If you give only sulfonylureas, it's sufficient.
We did that. We actually did only sulfonylureas. Things were not perfectly controlled. So we had to add the other two drugs, and it worked well. So MODY, the logic is they respond to sulfonylureas very exquisitely in the early phase of the disease. As the diabetes gets older and older, you will need additional therapies. Most likely they may need insulin at some point of time as well.
Whether precision medicine because all databases are needed in India, is it possible to do here with this cost?
I think let us not look at the genetic testing or the metabolomics or the proteomics of this testing. Let's look at just collecting basic level information at every single practitioner in the city. I mean, when the UK released their general practitioner database set, that is collection of clinical data for a wide variety of practitioners. I think if India can clump together data from our own private practice, meticulously collected, sincerely entered into a data sheet which is commonly shared, I think we will be able to provide to the world how we should manage diabetes in our country. I think we still ape the West for all these guidelines and algorithms, and now it is we're taking a different route of coronary artery disease prevention, other prevention. But for managing diabetes, I think we need a little bit of a precision that will focus on our own patients and how we respond.
I think that was a very complex topic, dealt very well. Thank you very much. I really enjoyed the talk.
Thank you.